All right, welcome everyone. My name is Johann Hari. I'm a research survey scientist at RTI International. I also have the privilege of serving as the vice president for the board of directors for WomenNC. Welcome to our second Lunch and Learn of 2022, our critical conversation series of community education events. Just a few months ago, we discussed the future of reproductive health access on the eve of the 49th anniversary of Roe versus Wade. You can access all of our recordings, all of our lunch and learns from the 2022 and 2021 and 2022 year on our YouTube channel, WomenNC Official, or from our website under the community education section. We have explored many issues that impact women, which include voting and sexual assault. Today's conversation, Substance Abuse Through a Gender Lens, explores the topic from a variety of angles. A few things to consider. Women face unique issues when it comes to substance use, in part influenced by sex differences and biology, and gender differences based on culturally defined roles for men and women. Research has found many differences in how women and men use substance and react to substances. Substance use in women tends to develop into addiction more quickly than in men. So much more that our panel of experts will let us know, it's so much more that our panel of experts will let us know about today. So today you will hear from Melissa Godwin, Leslie Ann Davis, Dr. Felicia Brown, Brittany Johnson, and Essence Harrison. And in that order, I would like for you all to please take some time to introduce yourselves and just tell us more about your background and the work that you do. Melissa.
Good afternoon. Thank you so much for having me. I am Melissa Godwin, and I am a clinical associate professor and a social worker, clinical social worker. And my appointment is with the UNC Chapel Hill School of Social Work. And I had, previous to this position, been with the UNC School of Public Health doing similar work. And so combined, I have been working in this area in North Carolina for just about 18 years. In both positions, I have been 100% funded on a contract with the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. And I feel like that's always important to note because there is a lot of great work happening across the state of North Carolina around women and treatment. And our state of North Carolina actually has been doing a pretty progressive and tremendous job over the last 30 years, which I'll talk a little bit more about, specifically when it comes to pregnant and parenting women. And so in my role, I provide training, technical assistance, and some policy support around these topics. And as part of that, one of the things that I helped develop is something called the North Carolina Pregnancy and Opioid Exposure Project. And that's something that came together through a statewide collaborative when the opioid overdose epidemic was really budding, and a lot of folks that had not previously really paid attention to substance exposed pregnancies were now paying attention, and it was an opioid exposed pregnancy. And there's some unique features and idiosyncrasies that come along with that specific substance and treatment and delivery and potential impact on the infant. And we realized that we really needed to get some fact-based information out there. And so that's how that project and the website with the fact-based information on it came together. Thanks so much for having me today. I really appreciate being here.
Thank you, Melissa.
I think I'm next, right? Oh, yep. Yeah, there's me. So, hey, everybody, I am Leslie Davis. I'm so excited to be here as well. Currently, I am working as a licensed clinical social worker, associate licensed clinical addiction specialist at Southlight Healthcare. I work with a transitional care team that has been working on a pilot from Wake County government, actually the state of North Carolina, but we got one of the Wake County bids to work with reentry and recidivism, reducing that, as well as overdose deaths, primarily in opioid use disorder, but we've expanded it for substance use, right? I think we have to pay attention to the conversation that we talk, the conversation about opioid use being an epidemic, and how there has been the benefit of having, opportunity and support around opioid use disorder, but also that is a part of a broader conversation, right, around substance use and what that means. And so we definitely at Southlight Healthcare, we have the benefit of working with multiple substance use disorders, not just opioid use. We do have a booming and expanding opioid treatment program, which I've definitely worked in a part of that, but also the primary goal of this grant or the pilot program funded by this grant, is to help with, like I said, recidivism or access to justice involvement, or reducing the access, right? So helping people divert from justice involvement. So if we have individuals in the beginning, before they receive the charge, we work with providing substance use assessments to see if this really is it a problem? Is this something that we can help divert them to? It's like a one-time thing. Usually a lot of the clients are men and women that are in the younger, trying to get them away from, making this a lifelong thing, but providing education and support, and then also not having this moment in life follow them throughout the trajectory, which can be part of an even bigger conversation, which goes to the reentry part of what I get to do. And so, helping individuals once they do have those charges, or once they are, incarcerated, or have more of that criminal justice involvement, we help with connecting them back to the community, with families, a bunch of different things. We usually base that on the social determinants of health, and increasing quality of life. One of the other things that we get to do at Southlight, we have so many other programs, the SAYOP program, which helps with substance use and getting people funding to help with housing, having that community connection with group. I used to say, it's 3 hours long, 3 times a week, for 3 hours, right? So up to 36 sessions, but we get a lot of connection in there. You're getting connected with other people, we're reducing the stigma related to substance use. And I think that's a huge part of the work that we get to do, right? We have to focus on like person first language. And usually I call myself we work with substance use, not substance abuse, right? Because that can look like totally different things. And I'm more about inclusion instead of exclusion. And if we focus on the words that we use, that helps people want to get connected to services. Because if we think about substance use, that's more about the connection to things. I also believe that stigma, comes from, the public view of things, right? And how we talk about where that comes from is the war on drugs, the people's identity and what that looks like. It has so many barriers, and I'm in the role now where I definitely work on, connecting people, helping people not have those obstacles with those barriers. So, barriers with employment, education, health, connection with families, a bunch of different things. Housing is a big thing. For us, when in Wake County, where I'm specifically housed, and I think all over the world, but right now there's a big shortage in affordable housing and what that means. And I think that's a huge barrier for the population that we get to serve. But I'm so glad to be here. I could go on and on. I'm going to stop. And so thank you for having me.
Thank you for that, Leslie. And I'll just note that inclusion is so important, and the words we use to ensure people feel included is even more important. So thank you for sharing that. Dr. Brown?
Yes, I'm a big fan of that as well. I think that really shapes who we reach and whether we retain the populations that we're trying to reach. So it's great to hear that. So yes, I am Felicia Brown. I am a senior research social epidemiologist at RTI. And I've been doing this work on and off for the past 16 years. And I have been working on research studies that address substance use in different areas. So currently I lead, co-lead, and support NIH-funded research for populations who use substances. And I focus on women of African descent particularly here in North Carolina, as well as in South Africa. Now for today, I'll just focus on our work here in North Carolina with Black women, but I just wanted to sort of give that context because that does in some ways inform our research. We learn from working in both contexts, even though they're different populations. There's issues related to stigma and things that do, matter in both contexts. So the work that we do is really risk reduction interventions. We develop and test interventions through randomized trials with the goal of reducing both substance use and sexual risk as it relates to HIV. And so just to be clear, it is not treatment, but we are focused on getting people ready for treatment in many cases and offering referrals to treatment. So Southlight has been a great organization, and my, supervisor and colleague, Dr. Wexberg, has a great relationship with Southlight. And so having those great connections as referrals is a really important part of the work that we do. And we are, so in our cases, not everyone is necessarily at risk for alcohol use or drug use disorder, but many are. And so, it's important for us to try to get them, at least if they're not getting into treatment, to get them sort of at that next stage for readiness. And I do just want to highlight one thing. It was sort of already alluded to, but just a lot of the work that we do is focused on social determinants and thinking about intersections. So I know that we are focused on, the gender lens, but also thinking about the intersectional lens because gender is a part of that. It's one of many things. And so I'm really honored to be a part of this panel and hear what everyone else has to say as well. So thank you for having me.
Thank you, Dr. Brown.
Hello, everyone. My name is Brittany Johnson. I am a clinician with Concord Methadone Clinic. It's McLeod Addictive Disease Center. What we do here is we serve a male and female population, but we try to ensure that our clients have the education on the medication assistance treatment to how it best fits their needs. We are very, very huge on educating our population on, especially our female population who are pregnant, on how methadone or the buprenorphine may affect the body or the baby. We provide resources. We are huge on connecting our population with the necessary resource, whether it be for mental health services or any OBGYN services, and housing is a huge thing here as well. A lot of our patients here, they do struggle with housing. A lot of our female population, they do struggle with some housing issues, whether it be that they're staying with a relative who doesn't believe in medication assistance treatment or they're in an abusive relationship. So we tried to provide resources necessary to, one, educate the family, or two, try to get that individual out of that situation to ensure that they are effective in treatment. But I look forward to talking about this subject with you guys today, and I'm very excited about this.
Thank you so much, Brittany. Essence?
Hello, I'm so glad to be here. I'm not quite sure how do I add on to all of the things that's been said, because I think, we're all in the same line of work, doing the same thing in some type of way. But my name is Essence Hairston. I am a clinical instructor under the Horizons Division. We actually fall under the OBGYN department at UNC. I spent about 11 years in residential treatment settings, specifically around addiction, until about 3 years ago when I migrated to our Wake County site to do more of the community connections, integrated work. My background is on reproductive and social justice in advancing the lives of perinatal and maternal people affected by substance use, trauma, violence, and incarceration. So Horizons has been around for about 26, 27 years in our Chapel Hill site. That is where we actually house our most enhanced services. So when Leslie's talking about the IOP, that intensive outpatient services, those 3 days a week, as well as our SACOT services, which is the 5 days a week program. So Orange County also, that's where we house our residential programs. So individuals can move into our residential programs for up to 9 months with their children. So either pregnant or they are parenting at the time. And we are equipped to house 30 families at one time. And we just recently found out we got transitional housing through a lot of advocacy and push on our state. On the state level, we have amazing state leaders. Melissa's also part of the advocacy working group who helps support our programs like Southlight and the RHCC program. So we are what I consider sister programs in a way. And then about, I'll say 3 years ago, we've been fortunate to receive private funding from the Foundation of Opioid Response Efforts to launch also some post-release services. So we are integrated with the women's prison here in Raleigh. So we have a prenatal sud clinic where we provide therapy, counseling before and after their OB visits, which we've been able to strengthen that continuity of care for post-release. And we've actually worked with Southlight and Cambridge Place and Cascade because we can't get everyone into Horizon. So it's definitely a team effort in terms of making those referrals. We always say recovery is, Horizons may not be for everybody, but recovery is. And so we definitely utilize our allies with our sister programs. Aside from that work, I do oversee our behavioral health and physical health programs, grant writing, and research. So I will say I'm 20% micro direct, 80% macro grant writing and research. And so I'm happy to be here.
Thank you so much, Essence. So next, we would just like for you all to elaborate more on the work that you're doing. And Melissa, we want to hear from you first.
Thank you, Tamara. I'd like to talk a bit about what I mentioned earlier, the work that the state has been doing for a long time in North Carolina through the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. It's a little bit wonky, but I think it's also important in terms of how things happen. All states get federal substance abuse prevention and treatment block grants from the federal government. And there's something called a women's set aside. So of that block grant, states are required to use 5% of the total money they receive on women's specific services. And North Carolina, when this began back in the early 90s, has always taken it really seriously. And they also applied with local partners, supported application for pilot treatment programs to provide gender then specific, now it's called gender responsive services for pregnant and parenting women and women seeking to regain custody of their children. And those pilot programs across the state have blossomed into what we now have, a statewide North Carolina perinatal, maternal, and CASA Works for Families initiative. And so there are about, at this point, I think 25 programs across the state, both residential and outpatient. And UNC Horizons in Chapel Hill and Carborough is one of those, as well as Southlight has one of those residential programs that's gender responsive. And the reason for that women's set aside, and the reason why there is something called women's gender responsive, is because it was recognized back around the time Roe v. Wade happened, actually, in the early 70s, that women's entry into recovery and engagement needed to be different, that what had been established and around for a long time in terms of a treatment approach was really a treatment approach designed for men. And women were not engaging, women were not getting treatment. So there was lots of different aspects to the work and the evolution. But one of the key things is something that actually Leslie mentioned earlier, and that is connection. And so there was a recognition that what women really benefit from is connection, as opposed to what we hopefully think of now as old school confrontation in a really aggressive sense. That really alienated women. It really heaped on shame. Shame does not, as we learned, help people heal. And so there was really this focus on acknowledging the reality of women's lived experience and the centrality of relationships and connection in their life, and working with that as a part of healing. And that can include her intimate relationships and her relationship with herself, her relationship with her family of origin, if she does or does not have children in her custody, her relationship, with those individuals, with those children. And that is one of the important gateways to heal. And so that has been the basis, as well as recognizing many additional aspects of a cultural experience of being a woman in our society. She tends to have more caregiving responsibilities for both children and family members. And so what does that mean in terms of barriers? And so there's barriers that are specific to treatment historically for women. And so again, this Women's Set Aside and the programs developed in North Carolina that are specifically gender responsive for women address all of that. And they're required to. That is embedded in the system. And it would be great if all programs, outpatient and residential, were prepared, and it would frankly benefit men as well, and non-binary people in terms of accessing treatment, because it means that anyone who has caregiving of children responsibilities get childcare attended to. So it's either provided, while they're getting treatment, childcare is provided, or it's arranged for. So it's acknowledged as a central piece to, because women historically were put in this position of, do I be a good mom and take care of my kids, or do I get treatment? And they're really stuck, we're stuck. And many still are. I mean, to be frank, I think that not enough people know about our gender responsive treatment services, and we can always use more and more outpatient gender responsive treatment services. The other big thing is transportation. And so if someone is under the initiatives, the perinatal, maternal, and CASA Works for Families initiatives, they're providing transportation, because if she can't get there, she's not going to get engaged. She's not going to get, into recovery. And we know that it can have a multi-generational impact. So it's really important for her, but it's important for all the people that care about her and that she cares about as well. So let's see. I'll pause there.
No, it was perfect.
Okay,
So
great.
I love how you talked about the fact that you want to give that woman space to heal, right?
Mm-hmm.
So that she can really get back into society and just be productive, but she needs to heal first. Mm-hmm. And then also this struggle that women have to really prioritize the needs of the family, but then also against their needs. So oftentimes our needs go abandoned, or they go unaddressed because we're forced to address the needs of the family. So really giving that woman time to heal and grow and prioritize her health is important, and it is generational. So thank you for sharing that, Melissa.
If I could mention one more thing, I think the other thing that was recognized early on in women's gender responsive work was the level of trauma that women were coming in with. It's just, like almost 90% of the women coming into treatment are carrying a high level, a burden of trauma, both childhood and adult trauma. And it's interesting because I'm glad that we are now, as a society, beginning to recognize and really talk about trauma. But it is a huge risk factor and burden for all individuals who are struggling with substance use, and in particular for women. And so that is something that has always been acknowledged and worked with in women's gender responsive treatment. And they have not been asked to sort of leave their trauma at the door and only focus on substance use. It's, all of them all of their experiences and struggles are coming with them. And these programs are ready to work with all of that. Again, the whole reality of her life and what that entails.
No, thank you. Thank you so much for sharing that, Melissa. Next, we will hear from Leslie Ann Davis.
Yes, thank you, Melissa and Tamara, for talking a little bit more about that. If I can expand a little bit, there were some things that I was like, yeah, shaking my head with what Melissa was saying. I think one of the benefits of being in this space is we are all doing the work, right? We're all doing it. Some things are just known to us. And I think it's a great time for us to talk about how we can, share that with everybody, right? And so I'm glad to be here for this space. So a little bit more intentionally about what I do specifically daily is that I work on a community-based team that works on access to care, specifically for individuals that are justice involved. And so when I say it like that, I feel like, it's either in the jails where I actually get an opportunity to go into the jails and do the assessments, start that connection there. So what we know is, the sooner that you can get connected to people, they're more in tune with or willing to invest in their own treatment, right? Because it's all about that connection to somebody, they know the person, they've seen me before they actually got out of jail. So it's more willing to connect with me and my team about getting access to care. We're more focused on what their needs are, not necessarily what we want for their life, right? So that's why I always say quality of their life. We're increasing the quality of their life. We have KPIs and all of those things, but we also want to make sure that we're focusing on what is the benefit of the client? What do we want their life to look like? And so usually when I go in, or one of my team members go in when they're incarcerated, we ask them, so, what would you want your life to look like a year from now? What does that look like for you? And so we make targeted interventions and things to help them with those, those life domains, right? So if it's, I just want an apartment where my kids will be safe and I don't have to worry about, A, B, and C. Yes, we are going to work towards that, right? What do we have to do in order to evoke that in their life? How can we help that and make that be beneficial for them? Because it's not necessarily about us and what we want. It's all about the client and what they want. And then we're on the ground. So we have a peer support specialist that meets with them, and helps, whether it's filling out job applications or going to a AANA meeting, meeting with them, meeting with them to help them transport to appointments, or maybe I just need somebody to talk to right now in this moment. And, it's not between 9 and 5, right? So what does that mean? Or let's go up to this McDonald's and have a conversation. Maybe I need access to food, or maybe, you can help me understand, and this gets more into our case manager as well as my role. And, maybe they have a CPS case and we want to help them, support them in that way, right? There's a bunch of different things that we get the opportunity to do. But I think, starting with meeting individuals while they're justice involved, right? Talking to probation and parole, helping support them. Because again, and you'll hear me say this over and over again, connection is a big thing, right? So if we can connect individuals to the supports that they need. A lot of substance use, in my personal opinion, has to deal with connection. Because if we don't connect with things as people, if we don't connect with things or people, we're going to connect with something, right? And so usually substance use is about connection. It makes us feel good. And I think a lot of the times we don't want to talk about substance use because it's taboo, right? And so I'm here to totally disband all of that, because nobody goes into substance use thinking that I'm going to be homeless, I'm going to have my kids taken away from me, or nobody's going to love me, I'm not going to be able to get a job, or all of those things, right? And so if we're honest about what substance use, how people get into it, usually to feel good, to bond with people, to connect with people, right? We can disarm all of those stigmas. And then that in turn allows people to want to get into treatment, right? They're willing. But I think, as a society, the goal is to help reduce that. I think previously it had been a moral issue, right? Or a criminal justice issue. And so now we have the benefit of having a social issue, right? A health concern. And so we're going to do that by helping our clients. And like I said, not just opiate, but also all substance use, because Southlight has been around for, I want to say 50 years. And we've done this work with substance use as a whole, right? Even just changing the language that we use, not substance abuse, but substance use, right? And I think one of the key things as you're talking to, individuals, or the work that we get to do, remembering that it has to be problematic use for the person, right? So not having your judgments on them, making sure that individuals understand that you are connecting and supporting them. But that also requires us to do our own work, right? So about helping us have our boundaries and making sure that we're doing what we can to show up and be the person that we want to be. But also letting them be their whole entire self, right? Taking up space and doing what they feel is beneficial for them. Prior to, being able to work on this grant with diversion and reentry, I was working as a SAYOP counselor and then helping engage individuals that had lost their connection, right? So they kind of disengaged for a little while. And I'm like, hey, come meet me somewhere. Let's go have a conversation, right? Let's talk about what was working and what wasn't working for you. They used to call it like going to the principal's office. But of course, that's not necessarily the case. I'm always laughing and smiling. And so they're like, well, let me tell you what went wrong. And I love that, right? Because we always can do better in the work that we get to do. And I think that's shown with a lot of the things that a lot of the benefits that we have. So with our SAYOP program, specifically, we have a housing initiative that goes along with it. So as long as you attend group, you show up, you do treatment, right? Whatever that means. We help pay for your housing stipend every week. We send it, and that comes out of our reimbursement for the services that we provide, because we truly understand that there are, like Melissa was saying, and I know the rest of the panelists are going to talk about all of those barriers related to getting in treatment, whether it's childcare or whether it is housing or whether it is, I have to decide before the buses were free and before COVID, right? If I can get on this bus or if I need to use this money to go get me something to eat, right? What is that about? And we wanted to make sure that we minimize all of those, as many as we can, right? But also, just making sure that we are here and we're listening and we're always wanting to do more effective, more inclusive work. But the thing is, we need to know exactly what the needs are, right? And so the way that we combat that, or the way we assist with that, is including people in the conversations, which I think is so key. And I feel like I'm going to pause there too, because I could go on and on.
No, really, really great conversation. I love how you spoke about just your impact to women that are incarcerated. I think oftentimes we frown upon people that are in jail, as if a mistake is like something that defines them for the rest of their life. And it's so unfair. And so our ability to really be able to provide support and uplift them and, connect with them, help them connect with others to really help them function in society and really enter back into the real world, I think is critical. So I thank you for that work. I think it's really important.
Thank you.
You're welcome. Up next is Dr. Felicia Brown.
Thank you. So I think it's a nice segue into what I'm actually going to talk about. In the research that we do and the work that we do, we work with a lot of different populations of African-American women. And in a recent project that we just finished, we ended up looking at, sort of within a population, within the sample, to better understand the different needs. And so one of the things we actually did look at was justice involvement, particularly people who had been arrested. And so this was a sample of young African-American women between 18 to 25, so emerging adults. And at the time, about 25% had a previous arrest. And what we found is that women who had a previous arrest, were 2 times more likely to say that they needed alcohol and other drug treatment. Which probably is not surprising to many of the panelists. But what we also found is that across all of the services we asked about, they endorsed greater needs. And so housing, employment, childcare, all of the things that were just talked about. And so it really drives home this point that, you have to think about all of these things and they intersect. So that's part of what we do, but really what we do is, like I said, we develop and test interventions. And as part of that development, we tailor. So part of the reason why we were looking at differences between justice involvement was to figure out, do we need to better tailor our intervention to speak to the unique needs of this specific group within, the population we're working with. So one thing I'll just quickly talk about is one of the things that we've done in our most recent work is think about how do we reach people, particularly young people. So in our intervention work, we've done it in sort of this group format in some cases. more recently here, we've done it in an individual format because a lot of the young women that we work with say that in the group format, they feel like they are, sharing their business with other people and they don't feel comfortable and they want to have that one-on-one, which is great. But as part of this last project we just did, we were testing a face-to-face individual session with an mHealth app platform. And so we have done some analysis of our findings, and we're finding that for certain outcomes, mHealth may be better than face-to-face, but they both seem to have some positive outcomes related to substance use and also satisfaction with the groups. And so what we're really now focused on is thinking about how do we reach people, particularly I think with COVID, and everyone's talking about, telehealth or, being sort of innovative, but also in North Carolina, we know that there are a lot of rural areas, right? And so in order to reach the people, who may not have access to interventionists or this, educational materials in other ways, how can we get it to them? And so we're really excited to, have these findings that support this idea that, either one is really great. So I think, innovative technology. And I think in the interest of time, I will stop there.
Felicia, really quickly, I know, as you mentioned, COVID's like a big thing, like with everything, like research across the board, COVID's really impacted us a lot. Do you think that impact is worsened for Black women, African-American women, or do you think it's the same?
Well, I think it's exacerbated the social determinants that unfortunately affects Black women and other marginalized, underserved populations. I know that there's been some work even at RTI that found that Black women had the greatest increase in alcohol use during the pandemic, but also populations of Hispanic or Latino women, I think Black men as well. There were other groups as well, but I do think in some respects that there have been greater increases or sort of, widening of health disparities. It's not always the case, right? But yes, it has definitely affected, I would say, unfortunately.
Thank you. All right, up next, we will hear from Brittany Johnson.
Yes, so I definitely agree with a lot of the things that the previous panelists have stated already. Here at McLeod, we are huge on person-centered approaches here. We try to definitely ensure that during our intake process, we ask about the client's preferences. What do they like to make them feel more comfortable? While they are here at the clinic, we try to make them feel as comfortable as possible, especially when it comes to childcare, because childcare is a huge thing, especially the hours that we're open. So a lot of the clinicians at our site, we offer like little things like toys or crayons and pads, just so the kids can be interactive while mom is in session. We even offer woman and child focus groups that will allow the parent to make connections with other parents that's in the program to help them, identify with each other, because identifying with each other and making that connection with each other is huge, especially because they know what each other are going through. We've seen, especially through COVID, a spike in trauma because a lot of our patients have lost loved ones, or just them not knowing how to deal with grief in general, and all they know is to revert back to substance. So we try to educate them on proper coping skills, or getting them connected to the proper resources that help them assist with grief. We're huge on mental health, so we feel like mental health and substance abuse is one and the same. So if your mental health is not in place, how can we get over the hurdle of the substance use? So we try to foster different options here at McLeod to where we're working on a pilot to see if we can get that mental health aspect connected into what it looks like here at McLeod, or just to connect you. We work with a multidisciplinary team to see, okay, this person they're not doing too well, but they're also pregnant. So how can we connect you? We connect with Cabarrus Health Alliance as well to ensure that they do get the proper care. We are huge on ensuring that our pregnant population, they see the doctor at least once a trimester just to up their dose, and definitely educate them on breastfeeding, because breastfeeding is so important. And a lot of our patients are scared to breastfeed being on methadone. We educate them on what it looks like after the baby is born and proper ways to taper off if that's something that they decide to do. But I'll stop right there because of time.
You could have kept going for another minute or so if you have more to say, but I love the individualized approach. You know, it's not a one size fits all, but just being mindful that, you know, pregnant women may experience things differently. Mental health is a huge thing and it impacts so much of what we do. So I just love that individualized approach that you all are taking within your organization. Okay, next up is Essence Harrison.
Yeah, I would just elaborate on some of the like key themes that I've also heard. I think when Melissa said gender responsive, like this light bulb went off, because we talk about trauma-informed care, but the language of trauma responsive. So we know the prevalence of trauma in the population that we work with, or anybody impacted by substance use. We know that is there. And so now we no longer need to be informed that, but we need to start responding to individuals in their trauma, to reduce re-traumatization, to reduce stigmatizing, because we know that the historical intervention, I'll say, to treat substance use, and somewhat so today, is that back in the 80s, the 90s, pregnant patients will enter into their OB appointments. And if they had indicated use or return to use, the police will come to their prenatal appointments, pick them up, and put them in jail, right? And so today, although we do not see police officers coming to prenatal appointments, what we do see is the involvement of the child welfare system, which is also a legal proceeding that is also determining, who is deemed a good fit, or who is deemed to parent, or when to parent. And what we know is pregnancy is actually a protective factor, right? And so when individuals become pregnant, right, that is like a huge opportunity for interventions to occur, because we get a lot of women who talk about, I'm only using to avoid getting sick. I won't help. And so when we think about the historical trauma of substance use, I heard someone mention the war on drugs, but even if we take it back a little bit, before the eugenics movement, you have all of this population, female-identified, women-identified individuals who were denied on how they should, access to their body, the autonomy of their bodies. Then you add the war on drugs, right? And so now you're moving into that intersectionality of race, class, sex, gender expression, and how that continues on in certain policies, and how that impacts, treatment efforts, individuals seeking care. And is that deeply rooted historical trauma that we're having to unpack, and that individuals are carrying. It's like that backpack, and they're carrying all of these backpacks hiking up this mountain, and it's like, let's take off this backpack. Let's help you take off this backpack. Let's help you feel safe. And so I really appreciate hearing people like highlight all of those things, and that's kind of what we want to do that's what we do at our Wake site. So I talked a little bit about our Orange County site, but our Wake site is a traditional outpatient service model, and I love our Wake site. Do not tell people that from Orange. I hope no one is streaming in from Orange, but I came from Orange, but I really love our Wake County site because we provide co-located services. Our Orange County site, they do have that evidence-based integrated care clinic, which is phenomenal, and it works. And when we're talking about those those barriers like transportation and childcare, sometimes we have to go to individuals. And so our program in Wake County allows us to integrate into other programs, because we did this needs assessment and Wake County was like, wait, we don't need another comprehensive Horizons program. We just want you to, align with the community agencies that's already here. And so it allows us to work with the OB care managers and CMARC and CC4C. It allows us to work with Wakebrook, UNC's Addiction Hospital. And that is the basis. The primary duties of my job is as the director of community engagement and integrated treatment services is to identify the agencies that are working with our population and how can we plug in the behavioral health aspect, because things are working well. It's just how do we create these integrated services in this co-located model. And so that's how we actually got connected with the women's prison. So our director of incarcerated health, Dr. Andrea Caneto, I forced her to be part of Horizons. We have a little bit of her time, but she is awesome. So she was providing the medication for opioid use disorder for pregnant patients, specifically in safekeepers in the women's prisons. And one day we had a meeting and I was like, you want to add that AT to the medication piece? Because we know the importance of behavioral health. We know the importance of connection. We know that, talking about attachment, talking about allowing that opportunity just for space. Sometimes we don't even, we just sit there and allow individuals to talk, whatever they want to talk about because of everything that they are carrying. And so, again, I just wanted to highlight everything that you all mentioned. That is, we do the same thing at Horizons, but more so of having to integrate and working with other community agencies and stakeholders to meet individuals where they are here in Wake. And that's what I really love about our Wake program.
Thank you for that, Essence. It seems to be just so much really great work happening in this space. And so really quick for you, if you had a magic wand and you could just change the world, what are some of the changes that you would like to see? And I want you to specifically think about changes in North Carolina.
Well, if I had a magic wand, I would definitely highlight these social drivers of health because I think those are the variables that continue to perpetuate substance use, perpetuate incarceration. Individuals are, we know, going back to Maslow, that individuals are more likely to succeed when their basic needs are met: housing, access to health care, access to education, to childcare, transportation. So I don't know if that was a fair response because I actually gave you multiple things in that one thing, but I'm going to go with the social drivers of health because I feel like that will capture all of the things that's missing for this population. And I feel that North Carolina has an opportunity to increase.
Yeah, no, that was a perfect response. Thank you, Essence. So for all of our panelists, again, you all are doing a lot of great work, which takes time, commitment, resources. And so and I would love to hear from all of you all quickly for 30 seconds, but what do you need to do your work better? What are some of the resources that you don't have? And is it just a money thing? Is it a financial thing? Or is it mental health support? Is it emotional support? What does that look like for you all? In essence, since you're here first, we can just start with you, and then you all just take your phone off mute and speak.
I would say probably the financial piece. I think oftentimes individuals see, there's these large lump sums of income comes for treatment, but oftentimes there's the perinatal programs, they typically don't get that funding, right? Or it's hard to access that funding from largers, right? So we have our state funding, which is like guaranteed funding, but outside of, our state support is really having to navigate research and grant writing to help also maintain the work that we do. But I think that will be don't want to speak for everybody, but I think the financial support and piece will support, and not just for creating treatment, but investing in treatments that's already working, and to build on the things that are already working in the community. And I will add to, I guess, education and awareness too. So the financial piece, but also the education and awareness, recognizing the needs of the population will also be helpful if I had to take the financial piece out of it.
Would anyone else like to share? I would love to hear from others.
I can go. Oh, sorry.
I'll just
Yes, Melissa.
piggyback onto what Essence said. I think what I wrote down for myself is really public education and awareness and understanding about substance use disorders as a health issue, not a moral issue. I think all of our jobs are made harder by the layers and layers of morality and stigma, within individuals, within families, within communities, and within politics. One of the challenges that comes up every few years are the considerations of making laws to, in North Carolina specifically, jail women who are pregnant for using substances. And that is based on a moral approach rather than a health-based approach, because if the concern is the pregnancy outcome, being incarcerated does not contribute to good pregnancy or birth outcomes. We know that there's lots of research and science to prove that the best approach, which we have been doing consistently for 30 years in North Carolina, is to connect her to treatment, not to incarcerate her. But it does take time and effort and energy, including from people on this panel, every few years to really advocate and try to educate policymakers to not pass those laws, and it's ongoing. And so that's one plug I'll make.
Thank you, Melissa. Go ahead, Dr. Brown. Did you want to say something?
Well, I'll be quick. So I would say one issue is sustainability of interventions, and this idea that I think, Essence, you were saying that, right? Like, so not reinventing the wheel, right? So, once we find something that works, obviously, you have to modify it and refine it, but at the same time, like, how do we scale it, scale it up? How do we get buy-in from other people? And so that's why I'm really excited about the mHealth, also because I think it allows for greater sustainability without sort of having a lot of like person power behind it necessarily all the time. And then I would just also say, from a research perspective, just continuing to make sure that when people are doing these large studies, that they're looking at these intersections so that we can use that to write grant proposals so that we can, do these interventions. Because if you don't have these intersections, if you're not looking at gender and race and employment, all these things, then we don't know what the data are for that.
Thank you, Felicia. So I want to jump back to something that Leslie was talking about earlier and around our criminal justice system. Because I just feel really strongly that it needs help and it just needs more support to just make it better. And specifically when we think about marginalized communities, those are the people that are mostly impacted by our criminal and justice system. And so can you explain something more about like what's the difference between decriminalization versus legalization of substance use?
Yes, definitely. I'm so glad that you asked that. So when we think about decriminalization, it goes back to something Melissa said, and then also what I was saying a little bit earlier. We treat the substance use, right, as a health issue, right? We treat it as a social issue, not a criminal justice or a moral issue, which directly impacts, stigma, willingness to engage in treatment, people's own, their self-esteem, right? All of those things ties with that. So that's why stakeholder education, and, you know, advocating, like Melissa said, because I'm gonna channel a lot of what she said as I talk about this. I think that's key in letting those macro levels, so those higher level things. We talk about changing systems, right? And so when we talk about changing systems, you know, those other things will follow. It's not necessarily changing people, right? It's about changing the systems that have significantly impacted marginalized populations. And so if we decriminalize things, right, we don't make it an issue to be using substances. They avoid negative social outcomes, right, such as loss of employment or housing or a criminal record, right? And I can't remember who said it, but it's like this moment of something that you had done, right? And it goes on and on and on for the rest of your life. You have to continuously address it. You have to continuously talk about it. You have to continuously explain who that part of you is. And I don't know about you guys, but I imagine something I did when I was 19 or 18 or 17, I don't want to keep talking about that, right? I'm like, no, let's forget that part, right? And so we afford other people the opportunity to do that. But if we talk about legalization, you know, we remove all the penalties associated with personal use of a drug in possession. And so not necessarily saying that we're legalizing everything, but we're not criminalizing it. So making people have those internal, those continuous barriers related to connection and support. And I think that's something that would be so helpful. Back when we said, like, I revert back to the war on drugs a lot, because I think that was like the hugest push. If you were alive around that time, which I think most of us on this panel were, you see how commercialized it was about, this is a huge problem. We're going to take a war on this, and people who have these issues, we're going to make criminal justice take control of this, as opposed to making it a social, a health concern, right? And if we work on changing that, it would be so amazing. We would see so many people get into treatment. I think I want to say it's Portugal that they decriminalized substance use back in 2001, and so they've seen like a 60% increase in people wanting to connect to treatment, and that is amazing. We're not saying that's the only thing that you do, but that's part of what we do, if that makes sense.
No, that makes perfect sense. We live, we learn, and then we reform, right? And ideally, our criminal justice system is supposed to be the place where you reform and get better. And oftentimes we don't see that. So thank you for that, Leslie. Brittany, I'm just thinking about your experience. Do you feel like women have a harder time seeking treatment? And if so, what do you think are some of the causes for that?
Oh, absolutely. It stems from depending on their family background. If a lot of our female population, their parents used, so they used, and their parents feel like, well, I got off of it without treatment, so you should be able to too. So it's just trying to break that stigma about what methadone or buprenorphine is, to effectively get through to the patient. And then another big part that we realize is just letting them know that they're human. And I'm big on letting them know, hey, at any given time, something could happen in my life and our roles could be reversed. So what does that look like for you going forward? What do you want for yourself and your children that'll help you get forward? So it starts with allowing them to know that they're human, and their substance use history doesn't define them. It's a part of their history, it's not who they are. So just trying to break that barrier is the biggest part to making them successful while they are in treatment. And then we even, again, provide education to family if they want to go that route once they get safe and secure in treatment.
Thank you so much for that, Brittany. So we do have one question from Facebook Live, and I want to give someone 30 seconds to answer it because we're up against the clock. It's almost 1 o'clock. So the question is, opiate use is a problem, but what about alcohol misuse?
I love that. I'll kind of chime in really, really quickly. I think, previously what we were talking about, opiate use, I think, is on the, people are willing to talk about that, right? And so part of what we get to do at Southlight is we expand that conversation where substance use, right? It's not just opiate, it's alcohol, it's cocaine, it's crack, it's, meth, that substance use. is an issue, right? It's problematic, right? And so we have to identify for individuals, what is problematic use? Does it impact multiple areas of your life? What does that look like, right? So in the essence of helping people focus on getting access to treatment, we got to take that non-judgmental stance, right? So the thing that we all can say foundationally, problematic use, what does that look like, right? It doesn't have to be, you know, your life looks the same way as this other person, right? Why is it a problem for you? How can we help you so that it's no longer an issue? How can we support you? How can we connect you to other things that can help support you and not just substance? So yeah, definitely all of the substances. I agree. I think just we have the benefit of having this conversation because of opiate use has opened it. So let's put all of the substance use in that conversation.
Absolutely. Thank you. Well, thank you all. I mean, this was just a really great conversation. I appreciate the opportunity to speak with all of you all today. I'm sure everyone that's joined our Facebook Live has just been filled with lots of great information. For all of you all that have joined, if you want more resources, they're located on the screen. If you want to reach out to WomenNC, please feel free, and we can send these to you via email as needed. And yeah, thank you again for joining, and thanks to all of our panelists.